Welcome to Acute Conversations, the official podcast of APT Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm your host, Leo Arguelles, and in today's episode, our guest is Nicole Neveau. Nicole is one of our new co-hosts on the podcast, and she's the Director of Rehab Services at SSM Health St. Louis University Hospital. On today's episode, we discuss Nicole's journey into PT, experiences that led her down the acute care path, her passion for empowering rehab professionals, and how scratching a patient's back makes a world of a difference in the acute care setting. We hope you enjoy the show. All right, welcome to today's episode. And joining me today as our guest is also one of our new co-hosts, Nicole Neveau. Am I pronouncing that correctly? As I've introduced you before, am I pronouncing that correctly, Nicole?
I know you asked me on the chat form to spell it phonetically, and I wasn't quite sure. It's Neveau.
Okay.
So you kind of skip in Neveau.
Neveau, you go right into it.
There you go.
The emphasis. Fantastic. So, part of the purpose of this episode is just so that our listeners and our viewers get a sense of who you are as this new co-host and kind of what you've been doing with APT Acute Care and kind of how you fit into this whole ecosystem. So let me start off in terms of the first question. Nicole, how did you even get started in choosing physical therapy as a profession? Where's your origin story? How did it begin?
I know, don't we all? We all have a good origin story about,
right?
Either why did we not go into nursing, or why did we not go into med school, or, all these other components. And I think most people's origin story started as I was an athlete and I got injured. I was an athlete. I never had too many serious injuries. I will say that I actually really wanted to be a massage therapist. And the idea of using my hands to help heal people was something that intrigued me. So I would say that physical therapy felt like a calling of how I could take caring from my heart and my soul and give it to other people. And sort of one thing led to another, and went to Ithaca College for early admission. So sort of committed early and didn't look back.
Wow.
From there. So decided at a fairly young age, which I know is not everybody's journey, and that's okay. Yeah, here I am.
So how did you discover physical therapy? Was it through like your own rehab, or was it through other professionals that you had met to kind of make that jump from massage therapy to physical therapy?
That's great. I did a research. I don't know, probably research is not the right term when you're in 9th grade or 10th grade, right? But you have to write. I had to write a paper about what I want to be when I grow up, and I wrote that I wanted to be a massage therapist. And I'm pretty sure that there were several conversations with biology teachers and a student counselor at my high school that was like, well, why don't you take a look at physical therapy? And I had a good friend who was also interested in physical therapy. And so at the time, our paths were hopefully going to move forward together. They didn't, but that was okay. He went into business instead. And, so, yeah.
Very cool. And then, was Ithaca College, that was your undergrad? And then from there, you went into PT school. Nothing changed your mind while you were in an undergrad?
So actually I'm a little older, I guess. So the program was a combined program, so that you went in to get your undergraduate in exercise science and immediately went straight into the master's of physical therapy. And then you could tack on this extra 10 weeks to do the doctorate. I believe, if I remember right, we were the last cohort that did it in such a condensed way at Ithaca, and the last cohort where the DPT was optional. So most of our curriculum was like squeezed in pretty tight, and then we had this extra little 10 weeks to go from the master's to the doctorate, only because they had fed in some of those doctorate courses into the master's. The class after us was fully DPT all the way. So I think I got lucky in that. I don't know that I intentionally planned it, but sort of on a fast track there. And it was a great school. When I did my college tours, it happened to be a beautiful day in Ithaca. Little did I know how cold and how, I knew it could get cold, but it was so beautiful the day I went.
Right, right.
Like false advertising. No, Ithaca is beautiful and gorgeous, right? For those Ithaca fans, it's kind of the slogan. Ithaca is gorgeous.
And for those listeners that don't know where Ithaca is, where is Ithaca?
Ithaca is in upstate New York,
Mhm,
right on the tip of one of the Finger Lakes.
mhm,
And the college itself is like up on a hill. So we used
mhm.
to joke that you could always tell the freshmen from the seniors or the graduate students by the size of their calf muscles. Because you're just
From the years.
always walking up a hill. And then Ithaca, the town itself, has a lot of gorges that you can hike around. It's a college town shared with Cornell. So
Very cool.
it's a quite a fun little place in upstate New York where it gets real cold and it snows a lot.
Wow. Okay. Okay. It is funny. Just recently we had our new cohort over at the University of Illinois here in Chicago. They got started in the PT program. And it's so funny. Like we spend so much time with our students with their butts in seats. It's like, make sure you get a chance to kind of discover the area, walk around Chicago, or if you're in Ithaca or your East Coast, walk around the campus and, like different environments and different neighborhoods to familiarize yourself with, which is great. Now, going into PT school, do you already have an idea of what you wanted to do, or like what facet of physical therapy you wanted to go into? Because I hear a good majority of people, again, like you said, they were an athlete, they might have gotten injured. I want to work with athletes as well. And now you're here as a co-host of Acute Care Physical Therapies podcast. So what was the jump from physical therapy? Like when was the first kind of inclination towards acute care?
Yeah, that jump from athlete to sputum,
right.
or other bodily functions. That one,
right. How did that happen?
How did that happen? I think I didn't quite know. I think all I knew is I wanted to use my hands, right? So the idea of using manual therapy was appealing, and I pretty quickly then thought, well, maybe pediatrics. I love kids. I was teaching swim lessons and babysitting and doing all those things, but really didn't have a necessarily an aha moment even during school. And I think that's okay. I think sometimes people think, oh, sort of like the say yes to the dress phenomenon, where I'm going to put it on and it's going to feel right. And then I'll know exactly.
Right. That's a great analogy.
And that's not everybody's journey, and our decisions in a moment don't have to be the same now as they will be in 10 years or 15 years from now. We can always pivot and turn, and it's not a lifelong commitment to acute care. And I know this is acute care podcast, so I'm supposed to be selling the profession here. I genuinely feel like acute care is one of the best places to start. And earlier in my career, I had this mindset of, I want to just start at the beginning, where life is fragile. Just to appreciate the fragility in it all, and the resilience of humans, and how we can really overcome so much as a being, both physically, emotionally, spiritually, all the facets of recovery from being at your sickest moments. So I knew, when I graduated, I thought, well, first off, I wanted to get to Florida because I was freezing and I needed to warm up. So like number one was location.
New York, just find somewhere warm. Priorities, find somewhere warm.
Yeah. And, I think I applied to a few jobs, and I don't like to prolong decisions. So, first job that made an offer, I was like, all right, let's do it. And it was acute care at Delray Medical Center. Shout out to them. Shout out to their trauma team who took me under their wing and, taught me how to unfold a medical chart and tell someone's story and sort of go through getting into like, what does it mean to be medically complex? What does it mean to survive a traumatic injury? Yeah. I also became really interested. I did some rotations through the critical care unit. So the cardiovascular ICU, and stepped down for several months, actually maybe closer to a few years at that point. And then found myself over in the neuro ICU. And that's where I was really like, yeah, this is
This is my jam.
this is
It fits. This is
it
the
fits.
dress,
This
right?
feels good. I loved it. I loved the fact that you could do an evaluation and treatment like all together. Like
Right.
you're already starting to like help facilitate somebody's anterior pelvic tilt into sitting on this mattress. You're
Mhm.
already starting to help bring their posture back into midline
Mhm.
from the moment that you're in there. Even just doing orientation with them when you're introducing yourself.
Right. Right.
So yeah, I think I sort of found this love for that critical side, that step down side, and seeing that progress over time. So yeah, I think acute care sort of landed on me. I did go from acute care into rehab for 3 years, and then I went
Mhm.
over to outpatient for a little while, some neuro
Wow.
outpatient.
Great.
Um,
Oh, so neuro outpatient, not like a typical outpatient orthopedic, but more so like outpatient neuro, or maybe a
well,
combo, a little bit of both.
it was a bit of a combo, and that's probably why I didn't stay there too long. I'm gonna
Oh,
be honest.
I
Kind of don't love the ortho. I'm gonna well just I don't love doing ortho
right.
outpatient. It's not for me. And that's
Well,
okay. I tried it on and I didn't
right.
like
That dress didn't fit, right? It's just
it. It
didn't like
didn't. You're right. Yeah, it's too frilly.
right.
Let's be honest. I didn't really want to hear about someone complaining that they had a twinge in their shoulder. Not that twinges aren't real and not that it's not important,
Right. Right.
but in the grand scheme of what I had, really worked with to date, it didn't feel genuine in me to be there to recover minor things. I was much more interested in the gift of learning from my patients and their
Yeah.
resiliency.
I
Yeah.
do want to
So
highlight the fact that you
back to
said
acute care.
I have to highlight the fact that you said unfolding a medical chart. So when you say unfolding a medical chart, a critical care, I'm assuming that you mean like a physical paper chart that you had to unfold,
Well,
because
you
I
can
remember
see
having to do that
labels, right?
too.
No.
Right? It's like they actually have to. I'm like, okay, where are all these papers? Like, what do I even look at? Let me search for the tabs. Where's the where's the,
Oh,
you
first you have
know
to find the chart,
right? Yeah, let's take a step
and
back. Where do they keep the charts?
where do they in these racks? I mean, and or the physicians who have they have every chart in the whole unit in this stack in front of them, and you're like, I need. Can I see that chart? No, I'm using it. You're like, okay, let
Not
me
right
just sit
now.
here and stare at you.
Right. It's just stuck under like three other charts. It's like buried underneath
Yeah.
paperwork. That's so
Yeah.
funny.
So it definitely started with a physical chart. They transitioned over to electronic medical records shortly after I left. Grateful I didn't have to go through that experience with them. But the physical charts and literally turning the pages
Yes.
over.
Yeah.
I think I went into acute care, or maybe all new grads are like this. And it's sort of very linear, right? Like I wanted to go through the chart, page 1 through 10,
Hmm.
and leave with exactly what was going to happen when I walked in the room. Like I
Right.
wanted that. I craved it, that the security blanket of it all, of knowing every little bit.
That
And
order. Yeah.
right, having someone come to me and be like, you don't need to know every bit of this piece of information. You need to know the story about where they are. How did they get where they are now?
Hmm.
And I think of Dr. Levenhagen's critical lab value work,
Hmm.
and that
Hmm.
it's not about a cutoff or an
Yeah.
answer. It's not a
Yep.
yes, no. It's not a guideline, right? That we can turn to and say, this is the protocol I have to follow. In
Hmm.
acute care, it's about the story of
Hmm.
where that patient is right now, and about that risk adjustment of what as a physical therapist, I need to dose intervention to maximize their recovery without increasing their risk of harm at
Yeah.
the point where they are the most critically ill
Hmm.
that they've ever maybe been in their lives. So there's no one formula. There's no, okay, this patient had a stroke and I should see them 7 days a week for 23 minutes in acute
Mhm,
care.
mhm, mhm.
It's like, what's the risk of them laying in this bed
Right,
versus the risk of me elevating their blood pressure to the point where their hemorrhage might bleed further
right,
versus waiting for a helmet. Yes, we should have a helmet, absolutely. But if they have so much swelling that the helmet isn't going to fit and they're going to lay in this bed for X, on and on and on, there's got to be a point where that risk is worth the reward.
right,
And
right.
that's the story in acute care. I think that when you're doing a chart review and you're unfolding the story and using your acute care knowledge and your clinical judgment and being consulted in that line of work is really working with that interdisciplinary team to say, and this is where we need to go next.
Mhm.
Do you know what I mean?
Absolutely. It's funny you bring up, and we'll allude to this later, but last year or a couple of years ago at the Bridge the Gap conference, I think Kimberly Lemons, who is also, she does a lot of work through APTAQ Care. There was this one line that I thought was just so like impactful and insightful. She said, there's a difference between mobility and rehabilitation, right?
Mm-hmm.
Like it's one thing where, okay,
Goosebumps.
let's mobilize a patient versus like rehab and how instrumental we are in terms of our thought process and the decisions that we make. That's where the skill is involved, right? That's what makes us different than, let's say, an aide or a tech or an exercise physiologist or nursing or OT and speech. Like that's part of what makes us different, right?
Mm-hmm.
And having those skills to make those decisions. I always feel that on acute care, it's kind of like we're walking that fence of, I don't want to do too little, right? Because we don't want to have this patient just kind of stuck in bed. And if there's opportunity to give them these situations where they can start improving their mobility and start increasing their strength, we should. But then we also don't want to overdo it, like you said, right?
Mm-hmm.
And multiple systems, right? Whether it's it's their circulatory system in terms of their blood pressure or their breathing, are they in a vent or not, or from a
Mm-hmm.
musculoskeletal standpoint, like, yeah, they don't have a helmet, they might fall, but that's kind of why I need to be here, because I want to be there to safely guard the patient. I don't think there's anybody else on staff right now or within like the healthcare field besides the physical therapist to safely mobilize this patient, right? So
Mm-hmm.
again, the difference between rehab and mobility, there's some nuance to that, but that's also what I think is so fun and interesting. And those challenges in acute care physical therapy, I feel some people, especially students, right, like you said, as a new grad, like, let's be scripted, like day 1, day 2, day
Yep.
3, like what's the protocol? And some people, like, maybe it's good to start off with that protocol. You need those protocols at times, but also like knowing the rules and when to break the rules sometimes, right? Like
Mm-hmm.
in terms of guidelines, it's like, okay, the hemoglobin is a little bit low, but maybe they're chronically low. Is
Yep.
this worth the risk of, can we just get them to dangle at the edge of the bed?
Yep.
And I have students that are just like, wow, I never thought that would be so impactful, just to get a patient sitting at the edge of the bed. And they'll say like, I haven't done this in weeks. And just the fact that like,
Yep.
like my back was so itchy just laying down there. And now they know that they can actually pull themselves into sitting, and now their tidal volume is better, and it kind of helps this chain reaction. So again, when you talk about
Yep.
the stories, like I've seen those patients, I remember those stories. And that's why I feel like acute care, like it's definitely like a drama, right? In terms of like reading this chart, what happened
Yes.
to this patient? They came in for this, and here we are. And like, is today the day? Today's the day that they're going to maybe take their first steps or sit up for the first time, or maybe we can help facilitate that extubation. So I do feel, like I don't like to have drama in my life, but then you go work in acute care, right? So
Yeah.
drama showers left and right, back and
It
forth.
is.
So
It is. And
that's
that's
cool.
that's what it means to work at the top of your license, right? Like
Right,
that
right.
is the essence of it. I believe is that you're a consultant in that case. You're there to push a little bit more safely within
Mhm.
within what the evidence supports. So our role is to integrate what we know in the evidence can help somebody and bring that to the team and help our patients move forward. And the everything shows that the more we're involved, the
Yeah,
better the outcomes, right? So
absolutely.
it's so rewarding. I'm gonna go back to the itchy back.
Right.
Just how that moment for so many patients where you first sit them up and
Hmm.
I can tell you all they want.
Hmm. Hmm. Right, right, exactly.
Can you
exactly.
scratch my back?
Right.
That, it's just, it's an intimate moment to be, and maybe that goes back to the healing with your hands,
Yep.
right? Like
Absolutely.
it's really a rewarding area to practice in if you can manage and deal with, or look past the bodily fluids part
Right.
of it.
Right. So bring me up to date now. So that
Sure.
you were in Florida, right? You
Yep.
were working in critical care hospitals, and then now bring us to now where you're working now, and what's your role in your hospital system?
Oh, so I am at SSM Health, which is a system of hospitals here in the Midwest area. And I work specifically at St. Louis University Hospital. It's an academic medical center as part of an academic platform in the St. Louis region. So there's a pediatrics hospital next door and another academic hospital a couple miles away, all within the SSM Health
Mm-hmm.
area. I am the director of therapy services for acute care and for outpatient there. And so we have physical, occupational, and speech therapists
Mm-hmm.
on our team, a team of about 100 with, we have got rehab aides who are phenomenal. And so I know you brought that, how therapist is different in terms of that critical thinking side of it. And I can't say enough that rehab aides or assistants in the acute care setting are critical.
Mm-hmm.
They really
Mm-hmm.
help keep the gears moving with
Right.
so many moving parts in a hospital. Having that extra help to really keep things moving and help the therapist be primarily in front of patients
Mm-hmm.
is
Mm-hmm.
is wonderful. So yeah, we have a pretty large team. We do have an outpatient clinic that sees about I don't know, 5 or 6 caseloads of therapists in the PT side a day, and then a really strong hand OT program. So that's
Yeah.
sort of this thing that's attached to this hospital-based outpatient clinic that's attached there. But our biggest part of the team is covering the hospital side. And
Mm-hmm.
then that's at SLU, as we call it, St. Louis University Hospital, SLU H, right?
Mm-hmm.
As to not infringe on the university that's right across the street.
Right.
We have a really growing cardiothoracic program or stroke center and a trauma center. So we like to say that, no one really wakes up thinking they're going to come to SLU
Mm-hmm. Mm-hmm.
hospital. There's not a lot of planned admissions
Mm-hmm.
in this setting. So our hospital is kind of high acuity all the
Yeah.
time. And even when they are a bit more on the stable or less acuity side, they are transported to our sister hospital right down the street so that we can keep seeing that high level of acuity in our large ICUs. So it's an exciting place to be.
Mm-hmm.
You've heard one story, it's
Right.
just like you said, drama. Like
Right.
kind of get into it and really get to see how we can help our community. I think it's a really amazing place in terms of public health and access for St.
Mm-hmm.
Louis and where we are in the humans and the people that we serve.
Mm-hmm.
We accept a lot of transfers from rural hospitals that maybe need that higher level, that academic medicine level,
Yeah.
which is good and bad. I think there's pros and cons to being involved in that, but really thinking about that academic platform and using it to elevate the care that we do. So yes, right now, acute care, St. Louis University Hospital. I got to spend the day treating, I don't know, maybe 3 or 4 weeks ago, and it was so much fun. I had the cutest patients and felt a little rusty since it's
Yeah.
not my primary role at this point, is
Mhm,
really
mhm,
supporting those who are doing what we call the real work. Uh,
mhm,
but really, I think that my job or my calling at this point, although it might not involve my hands all the time or scratching someone's back all the time,
uh-huh,
is really looking at how I can take these 100 people and say, you know, how are we going to grow? How are
mhm,
we going to work at the top of our license? How are we going to advocate for our profession as a consulting service? Really breaking down some of those guidelines or policies. Again, coming back to this is not, oh, your hemoglobin is under, I don't know, whatever number. places have 7.5, 6.5. It's not about, oh, I'm going to hold therapy every time that someone's hemoglobin is this level,
Right.
or we need their INR to be right here, or we need this to be perfect.
Mm-hmm.
Really
Mm-hmm.
teaching people from the root and mentoring in that there's critical thinking, there's always exceptions. And how do we make those exceptions? And that's where I've found a kind of another sense of joy in my career of helping people grow,
Mm-hmm.
and mentoring them into flourishing therapists.
So
Uh,
I wanted to ask you, so what have you seen change within like maybe the past 5-10 years, both at your institution or just acute care in general, in terms of how therapists kind of approach their caseload or their workload in terms of, okay, these are these set numbers. However, like what can we do to go ahead and do our best for this patient, right? I think it's starting to kind of fade away more and more where the only thing that we do is ambulate patients, right? I hopefully that's moving in the right direction where that's not the only thing that we do. And I think part of that is the therapists that are out in the field are showcasing their skills, right? They're not just, okay, they can't walk, I can't see this patient, discharge or hold. It's like, no. I think that's through the professors that are in the PT programs that are teaching what we do, in terms of the skill of acute care physical therapy, and that it's not just ambulation. There's a lot of things that we can do that we can start in terms of interventions. But what have you seen on, boots to the ground in both your institution and PT in general? What have you seen change within acute care?
A lot, some good, some bad.
Mm.
Some stuff that you're like, yeah, this is right. And some where you're saying, I think we need to actively work against this.
Mm-hmm.
And it's complicated, and probably, we could have a whole nother podcast just on that question alone,
Right.
Leo.
Right.
So, I see that in a value-based reimbursement system, therapy services feels more crunched. So we sort of feel this squeeze. The days of having a therapist come into the hospital and get paid, and get in the hospital, get paid per the unit of service per 8 minutes that therapist produces are gone. That's not here anymore. It's not our reality. So in that days when we were paid per unit, it was a little easier to grow teams because you could show a return on your investment. The more therapists you hired, the more therapy you could provide per minute, and the hospital would make money from that. But we know that dosage of therapy, the more therapy they get the better, but it's not just the therapy, it's the more movement they get. Now, instead of sort of being, like you said, the person that just goes and holds the gate belt and walks them around the unit until you get to your 8 minutes or your 23 minutes or whatever that archaic system is with our pay per minute, our fee for service model. We really see this shift where we're starting to really see these value-based metrics coming in. How much therapy versus how much mobility, and going back to the quote from the Bridge the Gap from 2024, right? Like it's rehabilitation. It's not just schlepping a patient into a chair or walking them around the unit. We have to be more precise about how we apply our services and be a consulting service. So I've seen that change a bit, and what that feels like boots on the grounds is more managing your caseload. So many facilities that have you have more patients on your list, and you have to really make these autonomous clinical decisions about who am I stepping on the gas for and applying more of my time and effort to, and who are we sort of holding off on or asking our other interdisciplinary partners to work with us. Maybe it's OT one day, PT the next day.
Yeah.
And in the meantime, nursing is helping this patient get out of bed 3 times. Right.
Collaborating with nursing. Absolutely.
Exactly. So that it's not precise. It's not, oh, you're this time and this time and this time. It's much more, an effort together as an interdisciplinary team, which takes a lot of communication, a lot of collaboration. And so I find that that's what it's much more about, is the moving pieces and how we all work together for the same goal with the patient at the center. So I think that's a big change, but it also means that as clinicians, we're making decisions, that frontline are making decisions with their caseload every day.
Yep.
It's not a simple, here's your list of 6 people that you're going to go see. Don't stop until you see all of them. It's much
Mhm.
more like, what do your people on this list need to
Right.
maximize their recovery,
Mhm.
to help
Mhm.
with their discharge planning? And how are you going to let your day unfold? Sometimes you
Right.
have a miss, and sometimes it's been a great day. And that's acute care for you, but you
Right.
have to leave knowing that you did the best you could, applying you as a resource to this bigger hospital. We all want more therapists, trust me.
Yeah.
And I do think as more research comes out about the value-based metrics, like
Mhm.
how can a therapist really independently impact length of stay, readmissions, fall rates, quality outcomes, mortality, the more we can get into what is it that a physical therapist brings to that conversation and draw in a more direct line, the more that we'll be able to grow our therapy teams
Mhm.
back to a place where we have the ability to see every patient every day, if that's the
Yeah.
goal, but until we have the literature that supports
Right.
that.
With evidence, yeah, like
Yep.
showing in terms of the study, and
Yep.
I think, and I think that is coming down the pipe. And just
Yeah. Oh yeah.
talking to different people, there's some of the research that we're looking at big data sets, lots of information, and good quality. It's when you
Yeah.
talk about like
Right.
productivity. I said that, like the ick word,
Mhm.
productivity. I just
Yep.
remember, like, if I had all orthos, I'm like, oh, I'm hitting productivity for sure today. Like,
Yep.
we'll see them in the morning, we'll see them in the afternoon, we'll see them for a full, like the full time, and like
Yep.
those are pretty scripted. But I actually felt more fulfilled when, even though my productivity numbers didn't look that great, it was like, it took me a lot of time to coordinate, but Mr. Smith in the ICU sat up for the first time. And I think because of today, they saw that he was able to kind of get better tidal volumes, and the doctor saw it and the doctor was
Yep.
impressed. They're thinking like, hey, maybe we can facilitate extubation, get this patient really up and moving, and hopefully out of the ICU into the step down unit and whatnot. But
Yeah.
it's so funny how those systems come into play. So the other thing I wanted to ask you, we talking about evidence. You are helping out with Bridge the Gap. That's going to be coming up in
I
my
am.
hometown in Chicago.
Yep.
When is the next Bridge the Gap conference?
Oh, that is coming up. So it's one of those, the conference, it's every other year. And this way we can really focus in on that high quality acute care
Mm-hmm.
side. It's May 1st through 3rd, 2026. And those who have maybe attended before will always say, the reviews have been, it's a much more intimate
Yeah.
experience if that's what you're looking for,
Mhm.
right here in Chicago, or right there in Chicago with you. So kind of middle of the country, so it's not too hard to get to from a lot of places. And you really try to keep, one of our goals is that it's engaging conversations during the
Mhm.
conference, and keeping it on a more budget friendly, conference, so as many people as we can get to come, head on over. We are saving the date, sending out save the dates right now, and the call for abstracts will be
Ooh.
coming soon, which is really exciting. And I think there was a blast that went out on Critical Edge
Mhm.
yesterday, if I'm
Okay.
not mistaken. But if you haven't seen it yet, keep your eyes open and save your calendars for May 1st through the 3rd, 2026,
Mhm.
and hopefully. Oh, I know. I shouldn't even say hopefully. I know it will be a great conference, and so many little pearls, like you mentioned, from 2024 that we brought. And I feel like when 2024, and I don't remember all the details, but just this incredibly engaging conversation with the presenter and the crowd, and just like,
Yeah.
I think we could have spent all day there talking about this, kind of the same topic of what you just asked me, which is like, how is acute care changing, and how are
Mhm.
we shaping this to move forward, and how do
Right.
we become, instead of just the the service that comes in and writes a note for discharge authorizations,
Mhm. Mhm.
instead of just the person that comes in, oh, can you get my patient to the chair?
Right.
Um, you
Right.
know,
Right.
how do we band together as a profession and say, hey, we are we are skilled, licensed, critically thinking people who have so much value to bring in the acute care setting, and really looking at the innovative ways, both in academic medicine and also in rural health and everything in between. How are people doing that? So
Mhm.
we can come together. Yeah.
I
Yeah.
love how you had framed it as we looking at ourselves as consultants. We have
Mhm.
this body of knowledge that rivals, in terms of like anatomy and physiology, we're right up there with the med school students in terms of the knowledge that we learn in school, right? In terms of the anatomy lab, it's the same lab that the med school students are using. But our expertise in terms of human movement, that's where it comes into play. And what that means, human movement here in the hospital, but also down the line, the environment that this patient is going to go back to, right? Are they going to have
Mhm.
family members? Do they have accessibility? Are they going to need assistance? So just looking at yourself as a consultant, you have like this specialized knowledge and how you can kind of help in terms of this person's, in terms of their needs and wants, right? So I think that's such a great way to kind of frame things. And then the
Mhm.
other thing about the Bridge the Gap conference, I think, is that, again, last time it was like, was it capped at like 200? Like, again, it's not like CSM is
Mhm.
huge, which is awesome, is to be
Yeah.
in an area with thousands, tens of thousands of therapists. But with Bridge the Gap, against what's cool is that the speakers are literally like you're in the
Mhm.
room with them, and right after their
Mhm.
presentations, you can go right up to them and kind of ask them, the question. So I can
Mhm.
definitely validate that in terms of the intimacy of being able to have these conversations. Are there anything specific that you're looking for in terms of abstracts that people are submitting?
Yeah, I think our biggest thing is looking at how are we using innovation in practice. So coming back to the name of this conference, bridging that gap from
Mhm.
evidence to practice, has always been the theme associated with the acute care bridge the gap conference. And at this point, there's a lot of talk about how are we in practice collecting and creating evidence, and then,
Mm, mhm.
showing, are we doing what we say we do?
Right.
So in that, really cu looking at all different sizes of facilities, all different kinds of practitioners, because again, what is what can be applied in the setting where I'm at,
Mhm.
a smaller to medium-sized academic hospital with a platform and a system where we have supports with a university right across the street, is a very different application of methodology than in a rural hospital, or even in a hospital that's on the outskirts of a city that is working its best to keep its doors open.
Right.
So I think just trying to really bring in abstracts that look at innovative methods of collaborating, of how we use education. We are very trained and knowledgeable, and one of our biggest superpowers is
Mhm.
our training in how to educate others.
Mhm.
So not
Mhm.
only are we the people movers, but we're there to empower our patients in autonomy, and to let them know, hey, this is what happened, and this is what might happen next, and really
Mhm.
be that voice that's like educating them while scratching their back. Do
Right.
you know? So I think the conference is going to be great. I'm super excited. I hope you're going to come this year. I know last time we were on the planning committee together and got to plan a nice run, a beautiful
Yes. Yes.
run. I'm really looking forward. Chicago is my favorite city, and I'm just really
Thank
looking
you.
forward to getting out there and meeting
Yeah.
everybody and seeing everybody.
May by the lakefront, yeah, it's amazing. And I think we just did a short run for whoever wanted to go out and just kind of,
Mhm.
like we're sitting a lot during the conference, so it's like might as well like start off on the right foot, get out, get at the
Yep.
lakefront, get a quick run in. So thank you, Nicole, for pitching Bridge of the Gap, and thanks for being a guest today. And I think it is time. So we're gonna do rapid responses, but because Nicole is one of the co-hosts for our podcast, we're going to go back and forth. So it's not just going to be me blasting Nicole with these questions. We'll have a little bit of interplay. We'll go back and forth. So I'm going to go ahead and I'm going to set up the timer here.
I'm going to be honest, I'm really nervous about this part.
Asking the questions or being asked.
I think, trying to answer quickly while finding the next best question to get you stumped.
Oh yeah, it's a little bit tough, but we'll keep it friendly. We'll keep it playful. All right. And I'll start off with the first question. You ready?
Okay.
All right, let's get started. All right, rapid responses. Nicole, are you a cat person or a dog person?
Oh, a dog person. You could probably hear her whining during this. Definitely a dog person.
Cool.
All right, Leo, would you rather be able to fly, or would you rather be able to swim underwater without coming up for air?
I would say fly, because Chicago traffic is a pain in the butt. So if I can get back and forth from my house to UIC, flying hands down, just as long as I'm not in any of the, getting in the way of O'Hare Airport or the Midway. What's your snack personality in terms of snacks? What snack best represents you?
Oh, just all the time. I don't even know that there needs to be one. I am a snacker. I love
what do you like to snack on?
Chips or cookies, or you know what? I love coffee. So I drink a lot of coffee. So that might be, if I had to pick one snack forever, it would be coffee with a lot of cream and sugar in it.
Oh, so you like cream and sugar with a splash of coffee in there, right?
Yep. So along the same lines, Leo, what's your dream vending machine item?
Ooh, dream vending machine item. Oh, you know what? This is just because my history Pop-Tarts. I know they're so bad for you, but there's something about, I just remember being in high school, like, oh, they got the Pop-Tarts in, and they last forever, probably circa like 1997. Like, this is still probably good. Still probably good.
So it's a great way to get a good, 500 calories in, like
exactly, 50 grams of sugar.
Yes.
Nicole, if you had someone narrate your life, whose voice would it be? Who would be your voice for narrating your life?
Oh, I don't even know. That's a really hard question. I will tell you, I just listened to a Taylor Swift podcast with her boyfriend, fiance now, right?
Right. Fiance now, I heard.
And she has a really nice presence. So let's just go with Taylor Swift. I feel like she's just always dropping these lines of knowledge, and maybe she'd make my voice a little bit better, right? And
or
maybe
she would
millions of dollars.
She would have narrated to your story. I always feel like Morgan Freeman and George Clooney. They've got good voices if they're gonna.
Yeah, that would be really, really great. All right, I got one more for you. Okay. Are you more productive when you plan something forward, or when you wait till the last minute?
I know I'm more productive when I wait last minute, but that's not the best strategy. I'm just putting out there. So all my students that are out there that are listening to it, just in terms of reality, is like, if I know that the deadline is here, I can pedal to the metal, but maybe not the healthiest strategy.
Yeah, so it's more like do as I say and not as I do, right?
Right, exactly. Yeah. All right, Nicole, final question. You worked on acute care when? Okay,
so I've been thinking about this, and I think it was your comment about the scratching of the back. Do you know that you're an acute care therapist when you have scratched your patient's back for the first time, and they just start melting and saying, oh my gosh, no one's done, I've been on my back in this bed. So that's
the little things.
It's
you
the
build
little
a relationship.
When you're just like, sure, I'll scratch your back for a minute, but then you're going to have to stand up and walk.
Right. Exactly. But they've got buy-in, right? Because you do a little bit for literally, like, you scratch your back, you scratch mine, but I don't need you to scratch my back. I need you to stand up and try walking maybe 150 feet. Let's try that today.
or 2 times 75. I think that would be the good.
There we go. With 2 turns. You have to have those 2 turns, right? Based on what systems you're using. But Nicole, thank you so much for being our guest today, and thank you for being a co-host for our Acute Conversations podcast.
Yeah, thanks. My pleasure. This has been such an experience, and to those who are part of acute care section and ever think about putting yourself out there as a volunteer, there's lots of opportunities. And I will tell you that I was very hesitant to apply to be on the podcast. I thought, there's no way I'd get selected. Why would I ever get selected for this? Just know that there are lots of opportunities, and that's how we grow. We keep putting ourselves out there. Sometimes it's comfortable, sometimes it's not, and sometimes it's terrifying, but look for those volunteer opportunities, and hopefully we see you in the next, Bridge the Gap Planning Committee or podcast, or in the special interest groups, advocacy, all of it.
Absolutely. Thank you, Nicole.
Thanks.
We would like to thank Nicole for joining us on the podcast and joining our team. Acute Conversations is the official podcast of APT Acute Care. This episode was hosted by Arguelles, executive produced by Katie Rito and Edward Mathis. Music by Alexia Action from Pixabay, sound effects also from Pixabay. For more information about APT Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us next time for a conversation with Jen Ryan. Thank you for listening, and may your shoes and scrubs stay clean today.